Okay. Thank you for joining our webinar today. I'm Yesenia Croft, Chief of the Health Account Management Division. I will be your host, and joining me is Rob Jarzambek, Chief of the Health Plan Research and Administration Division. Some housekeeping before we get started. This webinar will be recorded and posted to our website in the coming weeks and will be emailed out to all our registered attendees. The webinar is scheduled for 1 hour, and we ask that you use the Q&A feature at the bottom of the screen to submit your questions throughout the presentation. Also, a closed captioning link has been posted in the chat feature. I do want to highlight that our webinar today will focus on the 2024 health premium. We plan to have a special employer open enrollment webinar on September 7th, where we will cover open enrollment resources, 2024 health plan changes, as well as answer your specific questions related to open enrollment. Now let's get started. Today, we will cover a quick refresher on how we set health premiums, followed by a look at the final 2024 premiums approved by the board in July. We'll discuss the cost trends and some challenges facing the basic PPO plans and the decision by the board on changes to the CalPERS risk adjustment strategy. And there will be plenty of time for questions at the end of our presentation. And now I'll turn it over to today's presenter, Rob Jarzambek.
All right, thank you, Yesenia. And good morning, everyone, and thank you for joining us today. Let's begin with how we set premium. We significantly improved our process about 3 years ago in order to enhance the transparency and strengthen our ability to more accurately develop the premiums with the plan. We use our own claims data and require the plans to present their data in a way that allows us to build a baseline rate projection for each basic plan. We build estimates for utilization and cost trends, and then compare our rate with the health plan's rate proposal. This standard methodology allows us to conduct an apples-to-apples comparison to our projections and assumptions. It also provides insight into significantly more detail to understand what's driving trends at the plan level. The trend data includes utilization, unit costs, demographic changes among members, and geographic shifts. Then we risk adjust premiums using the risk mitigation strategy approved by our board in 2020. Doing this allows us to price plans based on the value of their benefit design and network, rather than on the concentration of healthy or unhealthy members in a plan. This pushes the plans to compete on the cost and quality of care they provide, instead of on their ability to attract younger and healthier members. I'll talk about risk adjustment a bit later in the presentation. Now let's talk about how premiums are set for public agencies and schools, as there's an extra step to that process. We start with the state premium calculated for the state of California and CSU members. The state is one employer, and although there are state employees in every county, there is one pay scale, the same classification, and the same benefit structure for all state employees. Therefore, there is a single premium regardless of where state employees reside. For public agency and school employers, like many of you, you have the ability to buy health insurance from sources other than CalPERS. So our plans must be competitively priced in the market. To accomplish this, we have 3 pricing regions for our contracting agencies. The pricing reflects the regional differences in the cost of care. For example, medical unit costs are higher in Northern California, our Region 1, by about 13% compared to the statewide average. Region 2 is about 10% lower than the average, and Region 3 is just over 20% lower than the statewide average. For purposes of this webinar, I'll use the state 2024 basic single party premiums and percent changes. The overall 2024 basic weighted average premium increase is 10.95%. The HMO average increase is 10.5%, and the PPO's increase is 12.2%. All the premiums, including the two-party and family premiums, as well as those for combination plans, will be posted on our website in the next few weeks on the Plans and Rates page. In the meantime, they are provided in the board meeting attachments, and we've shared a link here in the Zoom. These materials include all regional pricing. Let's move on to the cost influencers and trends. We'll first start at a high level. In general, here's what we are seeing when it comes to the cost trends and influencers that have the biggest impact on premiums this year. The first is medical inflation. The term medical inflation refers to medical trends and development and the increase in costs to support them. Medical inflation comprises a variety of components, and while it doesn't track one for one with general inflation, it is driving increased costs. Comprised in medical inflation are things like the cost of operating medical facilities, energy costs, materials such as steel and plastic, and also labor costs. So basically everything that it takes to provide healthcare services falls into this category. Another contributing factor unique to the healthcare industry is consolidation, which is also a component of medical inflation. Here in California, we see about a 30% spread in cost between Northern California and Southern California. This is because in Northern California, there are many more consolidated markets than in Southern California. And conversely, Southern California has much more competition than we have here in the North. Utilization is also a component of medical inflation, and it is higher than anticipated. We are seeing continued high demand for outpatient and professional services. In our PPOs, the utilization trend is up over 20%. We're also seeing variation in projected costs across plan structures. Our narrow network plans, so UHC's Harmony, Western Health Advantage, Blue Shield Trio, and Sluty Moss, have lower medical trend, but our larger plans, such as Kaiser and our PPOs, are experiencing higher medical costs. Pharmaceutical costs also continue to be high. While we continue to get best in market pricing through our contract with OptumRx, the cost of prescription drugs also continues to go up for everyone, and utilization is higher on pharmacy as well. Lastly, one of the drivers of the PPO increase is the surcharge approved by the board on the basic PPO plan. Built into the 2023 premiums is a surcharge on PERS Platinum and PERS Gold. For 2024, those surcharges will increase. I'll show more on this later. In the basic program, the PPO plans Kaiser and the PPO plans are experiencing the highest premium increases. Kaiser is seeing a premium increase between 12 and 19% depending on the region. And this makes it the highest increase amongst our basic HMOs. You'll see in looking at the cost drivers chart that most of the premium increase comes from a high medical trend. This high medical trend encompasses the medical inflation components I mentioned earlier. As an integrated system that provides care directly through their medical group and hospitals, Kaiser's exposure to medical inflation is much closer to real time. While their premium was very close to our projection, our primary concern is the higher medical trend they are experiencing. For example, their overall increase is almost double of the increases we are seeing from our other HMOs. As was discussed extensively with the board, Kaiser's model should be less expensive. It is an integrated system that by its structure limits the choices available to members. Despite this efficient model, Kaiser is projecting very high premium increases across California, and many organizations have experienced significant, meaning double-digit rate increases from Kaiser for 2024. So this is not just impacting CalPERS, it is impacting nearly all purchasers. The premium increase this year moved Kaiser to the high cost category within our portfolio, with only PERS Platinum and Anthem Traditional being more expensive. As we go forward, we will work with Kaiser to move them back to the middle of our book over the coming years. Both CalPERS and Kaiser are committed to working on that. Now let's turn to our PPOs. When we calculated the premiums at the beginning of the rate development process, The PERS Gold and PERS Platinum basic premiums were facing a 19.3% increase. This was simply not acceptable, but also not sustainable. Out of the total premium increase, roughly 13% is from stubbornly high medical costs. These increased costs are due to higher than expected unit costs and utilization, as well as member migration. Pharmacy contributed about 3.5% to the premium increase. In the 2024 premium, we are increasing the surcharge from 3% to 5% for PERS Gold and from 2% to 4% for PERS Platinum. The surcharge is needed to replenish the required reserves in the healthcare fund. The reserve deficit was primarily driven by higher than expected medical and pharmacy costs, as well as the 2022 premium buy-down, as well as investment losses. An important note here, though, although the deficit continued to grow over 2022, it has slowed substantially compared to 2021, so this is definitely good news. We know these increases are much too high for our members and for you, our employers. They also threaten the long-term sustainability of the basic PPO product. So we brought forward options to our board to begin to take steps to stabilize the PPO program starting next year. Let me first touch on the role the PPOs have in the program. The PPOs are important, vital plan options for our members. We know our employers and your employees count on having the PPO option, and we hear that expressed regularly by employers at our various stakeholder meetings and interactions throughout the year. The PPOs provide members the choice to see providers where and when they want. Members don't need prior approval to see a specialist, and there's no requirement to see a primary care doctor. The PPOs lack the care management that is central in our HMOs, but do provide the members with the most choice. Next is cost. Our PERS Gold plan is the lowest cost plan in 32 counties, or for roughly 25% of our members. PERS Gold is has the second lowest premium in 16 additional counties, which is for another 20% of our members. And it is one of the 4 lowest cost plan options available to all members statewide. I want to set the stage on the challenges we needed to address in the PPOs starting next year. The first and of course primary challenge is the premium. Without intervention, the PPOs would have experienced a 19% increase in 2024. With such an increase, we projected that 11% of members would leave the PPO during open enrollment, with the majority of those members being healthy members. With this migration, the difference between the health status of the members in the HMO versus those in the PPOs would continue to widen, with PPO members' risk or their health status increasing significantly. This would put more pressure on the costs and adversely impact the healthcare fund and our ability to replenish the PPO reserve. The PPOs have started to become unsustainable, making now the time to act. Our solution for 2024 was to propose to our board to begin to transition the basic plan portfolio to one risk pool. As background, in 2020, the board adopted a risk mitigation strategy that created 2 risk pools, one for the HMO and one for the PPO. This was a transparent, industry-based approach for risk adjustment, phased in over 2 years to reduce premium volatility. But what we're beginning to see is large migration and potentially significant migration from the HMOs to the PPOs, from the PPOs to the HMOs, excuse me. Again, mostly from the healthier members in the PERS Gold plan. Our intention was to eventually have one risk pool for all basic plans. But with the significant rate increases for 2024, we needed to transition to one pool sooner than anticipated, starting next year. We also learned that many purchasers already risk adjust PPO and HMO premiums in one risk pool. This includes Covered California and all state exchanges throughout the U.S. It also includes CMS, as well as other state purchasers, such as the Washington Healthcare Authority and Massachusetts Group Insurance Commission. This chart shows the risk scores, which is how healthy or unhealthy a population is, between the HMOs and PPOs. Plans with a score greater than 1, with 1 being the average, have unhealthier or sicker members. Plans with scores less than 1 have healthier members. As you can see, the PPOs in the blue have always had a sicker population or a higher risk population, especially when compared to the HMOs that are shown in orange. Under the current model of 2 risk pools, the PPOs would continue to struggle with the same problems we have today, and it will become even more difficult for us to solve them in the future. And this isn't just because the PPOs are unmanaged, it is because of the health status of the members who would remain in the PPO plan. What the lines show is the rapidly growing difference in the health status or risk mix of the PPOs and the HMOs if left unaddressed. Without changes, there will likely be double-digit increases for the PPOs in subsequent years. This is because it will continue to lose healthy members, and the premiums will need to continue to have an additional surcharge to rebuild the reserves of the healthcare fund. As a result of the increasing premium, most healthy members would leave the PPO for the HMO, eventually making the PPO premiums unaffordable for everyone. While the 3-year phase-in to 1 risk pool minimizes the impact to HMO premium, it is not enough on its own to reduce the PPO premiums to a level that prevents significant outward migration next year. To get the PPO premiums down to this level, we need to take some additional steps. The first is to make modest benefit design changes that increase the cost sharing for out-of-network care. Specifically, we are increasing the out-of-network deductibles by $1,500. So from $500 to $2,000 for PERS Platinum, and from $1,000 to $2,500 for PERS Gold. Making these benefit design changes will reduce both the Platinum and Gold's premiums by 1.2%. The second action we are taking is looking at network options to also reduce the premium. We are working with Anthem on their future contracts with facilities and physicians. Anthem will use their contract renewals as an opportunity to secure improved pricing where possible. The target we set for Anthem is to secure a 0.6% reduction through improved contracts by the end of this year. If Anthem is not successful in achieving this reduction, we will pursue the elimination of a high-cost facility in the PERS Gold network. PERS Gold, as you know, is a lower cost plan, and having very high cost systems in it does not make sense. Network adjustments for PERS Gold involve removing high cost facilities. Specifically, we are looking at high cost sites of care that also have lower cost alternative sites of care within the same geographical area. As we evaluate options, we want to ensure that members will still have access to other facilities with comparable quality. Any changes made to the network will be communicated to impacted members. With this effort, we are not proposing changes to the Platinum network. This is so that we can ensure members who want the greatest ability to choose providers and facilities are still able to do so. So, bottom line, with transitioning to 1 risk pool over 3 years, the proposed benefit design and network changes, the PPO premium increase of 19.3% is reduced to 12.2%. Here we show the PPO and HMO premium increases under the current 2 risk pool model and with the transition to 1 risk pool over 3 years. With the 3-year phase-in, which includes the modest PPO benefit design changes I just talked about, this led to a 12.2% PPO increase and an overall 10.5% HMO increase. The transition to 1 risk pool gives much needed premium relief to the PPOs while minimizing the impact to the HMOs. Here we see the entire basic plans in our portfolio by premium. While Kaiser has moved towards the higher end of the spectrum, there are lower cost options available to members in many areas, and our goal is to continue to expand them into more areas in the coming year. This was a key point in our recent HMO solicitation, and we set a very clear expectation with the plans that low-cost HMO offerings need to continue to be expanded into new areas for CalPERS members on a regular and ongoing basis, especially in Region 1. I'll conclude by saying that the healthcare landscape remains challenging, and even though this is the case, there are some plans that with increases in the 4 to 7% range. So this gives employees and our members the ability to shop health plans if they choose. Shopping health plans is the focus of this year's open enrollment season, which is September 18th through October 13th. I'll plug the open enrollment for employers webinar that is scheduled for September 7th. Yesenia will walk you through resources and information to help you have a successful open enrollment for your employees. In the next couple of weeks, you'll see emails and find registration information on our website. That concludes my portion of the presentation, and we'll now begin to take questions that we see coming in through the Q&A panel. So Yesenia.
Thank you, Rob. Yes, we have several questions. One that was a common thread that I think it's important to address first is the rates that are in the website say proposed, and the question is, are those the final rates?
Yes, and so those, they say proposed because we brought them to the board for their approval, and the board did give their approval at the July board meeting to approve the 3-year phase-in rate. So we're using the 3-year phase-in rate. So you see a 2-year phase-in out there and 3-year. We presented them with both of those options because that was their direction from the June meeting. They wanted us to analyze that, but the 3-year phase-in was approved. And so we'll be updating the plans and rates page in the coming weeks with that information. So yes, they are approved. The 3-year phase-in is approved.
Perfect. Next question. So with Kaiser being real time, should we expect greater increases for other plans in 2025?
So that is an excellent question, and a question we are asking all of our other plans. And so we do know that there's definite variation between what we're seeing with the some of our narrow network plans. So the other plans did have a much lower premium, medical trend for this year. But as things progress and as things move forward, we will be watching that very closely. So I don't have a crystal ball to say yes or no one way or the other, but that's something that we are definitely watching. Some of those plans do, however, have stronger contracts, and they have different contracts because they're narrow network. And so it might not be as significant as what we've seen with Kaiser, but it's definitely something we'll be watching very closely.
Okay. What is a surcharge and who pays for this? Employees when they're visiting the doctor, or an employer when they're paying the bill?
So the surcharge that has been added to the premiums for 2023 as well as 2024 are incorporated into the premium. And so it is paid there. It's additional surcharge that's added to rebuild the reserves in the healthcare fund. And so it's depending on who pays for the premium or how much the employer contribution is towards that premium, that is how it is being paid. We need to do this because in 2020 and 2021, we had some very difficult years. And so this is where we basically depleted all of our savings from the healthcare fund. So that's when I say reserves in the healthcare fund. We need to have at least a 90% reserves to ensure we have the funds available to pay for things such as what we have with the pandemic. And so that is what we need to do. We need to build back that savings account basically in the healthcare fund.
Is PERS looking at adding an affordable plan that we can offer to our public agencies, full-time, low-income workers? The PERS Gold PPO has experiencing significant rate increases, less affordable to those with salary increases lower than the rate increases. Please help us.
Yes. So the answer to that question is yes. We are looking at a more affordable option specifically geared, specifically designed for our public agency and schools. And so this is something, it won't be for 2024 or likely not for 2025, but that is something that we definitely have on our list. With our solicitation, the next 5-year contract for the third-party administrator of our PPOs, this is something that we are will be asking them about to help us come up with a product that can be geared towards our public agency and schools specifically for them. So that is even a lower cost option compared to where PERS Gold is today. So yes, it's definitely something we are exploring.
Why are those in PPO plans less healthier than those in HMOs?
So this is just based on who is really who is in the plan. And so people who are in the PPOs, they also, let me back up. The PPOs have less coordination of care. And so the members really has more responsibility to try to navigate the health system for themselves. And so they may not be getting all the routine follow-ups and all the routine checkups and things like that. Also, we do know that when members experience significant diagnoses, they do move from HMOs to PPOs so they can seek the site of care that they want to go to. And so we do see that also. So we have people in the HMOs, you'd be an HMO majority of your life, but then when you have a certain diagnosis, you may be switching to PERS Platinum so you can get that site of care. That's something that is not necessarily in network in the HMOs. And so those are the reasons that the PPOs are typically, that we do see the PPO members being less healthy or more costly. It's just the conditions that they have. And it's also the PPOs, they have the ability to go to any specialist without a referral. And so members have that freedom. And so when you have those certain conditions or diagnoses, people appreciate that and they migrate to the PPOs so they can go seek the care that they want to seek.
Do you anticipate the trends of these increases for the next couple of years?
That was a similar question to the one previously. We're monitoring the trends very closely with all of our health plans and carriers. We do know that some were much lower, or many of our HMOs had half of the medical trend that Kaiser had this year, as well as our PPOs had. And so it really does depend on the contracting arrangement and where they're located and what their contracts look like. But we were definitely watching that to see how soon and how much it might come and impact the rest of our plan.
Okay. How does the 3-year phase-in affect rates for fiscal year 24-25 and 25-26?
So the 3-year phase-in is designed to minimize the impact to the HMOs. And so this year we had, by phasing in, but taking a 1/3 of a step, basically, it was a 1.2% impact on the HMO premium. And so for the out years, that impact will be very similar to that amount. It might be less if the health status of the PPO members improves. It could be more if it gets worse. We are also, as I mentioned, we're going through the solicitation for a third-party administrator. It's currently Anthem for our PPOs. With that solicitation, we're also looking at other contracting arrangements. So by moving from a self-insured or self-funded product right now, which we are, possibly to a fully insured product, that may also impact that number, that 1.2 approximately percent impact on the HMOs. And so it's approximate, but there could be things that change it, that either bump it up a little bit or bump it down a little bit, but it'll still be about that, in that range for the 3 subsequent years. So 24, 25, 26 plan years.
And Why is the health plan zip code locator on the PERS website not updated during open enrollment? This makes it difficult to choose from plans for the upcoming year that may not be available to our area. So I can take that one. It is updated prior to open enrollment. It's typically updated on the same day that the health plan statements are released, which this year will be on September 11th. So it'll be updated for your employees to utilize to make those informed decisions when they're shopping for health plans. Are you removing Health Net SmartCare for Region 3?
So yes, Health Net SmartCare is no longer in the CalPERS portfolio starting 1/1 of 2024. And so we brought this to the board for their input and approval when we got their approval for the next 5-year contract of our HMO plans. So yes, it is no longer in the portfolio. This is because the Health Net requested to exit the Bay Area. That is where they had the majority of their lives. And so having a plan, having them in Southern California only did not make sense for us and was really unfair to some of the other plans that have both a Northern California and a Southern California footprint.
Did CalPERS consider separate risk pools for active members and retirees that are not on the Medicare plans?
That question again, please.
Did CalPERS consider separate risk pools for active members and retirees that are not on the Medicare?
So we did not consider having separate risk pools for active employees and early retirees, meaning those who are retired but not yet on a Medicare plan. So we are risk adjusting everything together because that would have the greatest impact to minimize and improve the risk scores for all of our members. By separating them out, then you would have even a more difficult time of pricing those, because the older people who are between 55 and 65, let's say, or 50 and 65, their risk scores would be far higher than those who are like on the younger end of the spectrum. So we needed to make sure that they were all in there together, so it would balance things out as best that it could.
We might need a little more clarification on this question, but what are the mitigating factors?
I don't know what that means.
Okay.
I don't know what that's in relation to. So just ask that question again, please.
Okay.
Or tie it back to what we can get to it.
Yeah. At the prelim presentation, I believe the board asked CalPERS staff to go back to Kaiser and ask them to reduce their proposed increases. What happened during those discussions?
So that is correct. And so we had gone back to Kaiser and we had already gotten as low as that we were going to get with them, and also because it was also in line with our projection. And so starting off, Kaiser came in with over a 16% premium increase for next year. And so that was where we started. We got down to under 10%, which was in line with our projection, with what our buildup for them showed. As I talked about, we changed our process about 3 years ago, where we are building our own rate and then we're comparing it to each plan submission. And so by doing that, we knew that 16% was not accurate. And so by having that information with us and with our new process, we were able to go to them and talk about those differences and show them that their 16% was not actually correct. And it was more around under 10%. And so we got them to the level under 10% for their rate. And so we were very pleased with that. I know it's still high, but it is actually reflects their rate for CalPERS. So that was what we were able to do with Kaiser this year.
Will we get information on the high cost facilities that will be removed from the PERS Gold Network?
So we're exploring that right now. So we will, if we need to go down that path and Anthem's not able to make up that 0.6% reduction through their contracts, then the impacted members will be notified of that. It'll also be updated in their search tools online, so they'll be able to see which medical facilities and physicians are no longer available. We will also, of course, update ours, so members know that as well.
Okay. How does CalPERS investment earnings impact health premiums, or does it? I know it affects pension costs, but does it also impact health premiums?
It does not impact health premiums at all. Separate lines of business.
Will there be consideration of changing the region's makeup? Will that help with future pricing?
So this question gets at our public agency and schools pricing region. So yes, we're committed to looking at those on a regular basis. We'll likely do that in the next few years. We did it 4 years ago or so, and so we'll look at where those lines should be drawn, and we'll do that evaluation once every few years, like 5 or more years. They typically don't change that often, so we are committed to looking at that, and also the factors that we use for them.
Is there any way that the PERS board can announce proposed rates or final rates earlier in the year? Announced rates this late in the year limit agencies exploring other available options.
So we are actually one of the earliest purchasers to go through our rate setting process and announce our rates. And so previously we did it in June. And what we realized there was that we did not have enough information, enough data to make the most informed decision. And so we did push it to July. We now approve them in July. So that gives us additional data from the previous year to come in due to the claims lag that is very common with healthcare. This is this is the time frame that works best for us to make sure we have the most accurate rate for all of our 1.5 million members.
Is the calendar year deductible for the PPO plans increasing as well?
Only the out-of-network deductible is increasing. The in-network deductible is not increasing. And so this is where it's a change. Before they were together, they were one deductible. Now it's splitting into two. So the in-network deductible will remain the same, and the out-of-network deductible will increase. I should just mention the out-of-network deductible increasing from by $1,500. Through our analysis, we noticed that only 2% of PPO members actually went over their out-of-network deductible limit in 2022. So this is going to impact very few members, but it will create savings for all of us, because when that member does go out of network, the plan is still paying 60% of that. So the member pays 40%, the plan pays 60%. So all PPO members then are paying that 60% for that member to go out of network. And so this will really encourage members to go to in-network. In-network, we have much better pricing on, and we also have insight into quality. We have no idea what the quality is for when members go out of network. And there's a reason these facilities and doctors are out of network, because they're not meeting some criteria, whether it's cost or quality that Anthem and we have set. So that's where we really want to guide people and encourage people to use in-network facilities where possible, whenever possible.
Will CalPERS look into an HSA-compatible PPO plan?
We haven't done that, but we could. That might be something that we consider for as we were talking about the product for public agencies and schools, having an HSA component for that. So thank you for that suggestion. I'm going to write that down as a component to help us get to something where we have a lower premium increase or lower premiums for that product.
Are there any updates to the 2023 summaries of benefits and coverage for the Gold, Platinum, and PORAC plans?
The benefit design changes that we talked about here will be updated in those, updated in the EOCs. statement of benefits. They were updated if the information that's changing is actually in them. The change I'm talking about also does not have an impact on any of the association plans. It's just the PERS PPO basic plan.
Thanks for the response, but public agencies are in serious trouble. 2 more years without an affordable plan is really bad news. Is there no option to request something sooner than 2025?
Sooner than 2025? It would have to be a new plan that we would incorporate into the solicitation already. Because the solicitation is, the new contract is set to begin on 1/1/2025. And so that would be pretty difficult to be able to do that. And especially if we have a new third-party administrator and a new and other new vendors that we're working with in that space. So it's definitely on our list of things to consider, and we're exploring. I don't know if we can get it pulled off by 2025, but I'll definitely take that back.
Why isn't the open enrollment webinar being conducted sooner? That gives us less time to prepare a presentation to employees before open enrollment. That's good feedback that I'll take back for next year when we're planning the timeline for the webinar. So thank you for that. We are also doing a lot of communication to our members with emails and letters and custom messages. So we're providing a lot of communication to our members as well. But I appreciate the feedback, and I'll take that back. If a city falls within a region, why are those plans not available based on their home address? Example, is Kaiser in Region 1?
So if a plan is available in the area, it's available to everybody, regardless of what region you are in. And so depending on whatever zip code they're using as their eligibility zip code, if it's available there, and it would depend, if it's available there in that zip code, then the corresponding regional pricing would be associated with it.
Do you have any updates on the contract negotiations between Salinas Valley Health and Anthem Blue Cross?
I had a meeting with Anthem yesterday, and they are still ways apart, but they're still trying to meet some sort of make some sort of agreement. So I don't have any more update that I know that they're still talking, but I know that as of this night, the termination was effective as of yesterday.
When will the letters go out for employees with substantial rate increases? Will the date be different for retirees? So they are scheduled to go out the last 2 weeks of August, and they do go out in phased mailings. There is no difference between actives and retirees, but it is the last 2 weeks of August. You addressed the HMO increases to be the same at 1.2% per year through 2026. Does this mean that PPO PERS Gold will remain at 12.2% each year?
So I'll clarify that. So the HMO increases would be 1.2% or approximately 1.2% due to the transition to one risk pool. And so that 1.2% would be on top of whatever increase or decrease the HMOs may see in coming years. So the HMOs are not going to have only a 1.2% increase. It's the 1.2% or thereabouts will be added to whatever happens with those plans, whether they go up, down, or stay the same. And then same for the PPOs. The PPOs is just 12.2% this year. So I don't know what the rate increase will be. The rate will be for an out year. We're up, down, steady, whatever. Again, with the new, potentially new third-party administrator and a new contract that we're seeking, it could be definitely be different. And I don't know which direction it might go in. Things typically always go up, but we want to like stabilize them so they're not double digits and it's just more acceptable if that's even possible increases. But there's a lot of things changing in the PPO space with our contracts in 2025. So the next plan year that we'll be doing rates for.
Since Health Net is leaving, is there an alternative for those enrolled in the plan in 2023 and chose to passively enroll, or do they need to actively enroll for 2024?
So with Health Net's departure, we have it set up in case a member does not choose a different health plan in open enrollment. Well, first and foremost, we're encouraging members to choose, so they know they can have make that decision themselves and they can evaluate their options. Should a member not decide to choose, then we do need to transition them to another health plan because they cannot remain in that plan. So they will be moved to Blue Shield Access Plus. So that's both in Northern and Southern California, with one exception. In Napa County, those members will be transitioned to Western Health Advantage. This is because Blue Shield Access Plus is not available in Western Health Advantage. I'm sorry, it's not available in Napa County. So one little caveat there just for the Napa County employers and members. But Blue Shield Access Plus will be the default plan should they not choose to make a plan change. But again, we're encouraging every member to make a plan change because maybe Blue Shield Access Plus is not the right plan for those SmartCare members.
I thought the ACA and introduction of additional carriers to the CalPERS health plan and preventative health program measures like smoking cessation, diabetes prevention, and pharmacy benefit changes were supposed to help deal with the increasing cost of health insurance. Do you see any of these mitigating measures actually make an impact? Oh yeah, I know they do. And so we don't have our clinical team on this webinar, but we do have programs for all of those things that were said, and they do make an impact in not just the health outcomes and improvements that members are getting, which is the most important thing, but also that on the financial end, that we're not paying for all of these conditions that are treatable and preventable in some cases. In addition to premium increases over the 3-year phase, what other changes can we expect? So we can expect changes in the PPO space because we're going through a procurement right now, and we're going through a solicitation right now. The solicitation is very different than any solicitation we have done for a third-party administrator of our PPO. Specifically, we're looking at the appropriate networks and potentially network tiering. So having high quality, lower cost providers more readily available when and where possible. Also, we're looking for a population health management component to it. So as I mentioned earlier, the PPOs, they do lack that coordination that is central to the HMOs. And so that can mean that PPO members don't know where to go or have like choice overload when it comes to where they should actually be seeking services. And so this population health management entity that we're seeking, or component of the TPA that we're seeking, is to really help guide members to the most appropriate site of care when and where they need it. And so this is something that it will be new and will hopefully help guide members to that care and be in a customer experience, but also be a customer experience improvement point too, where they're not being that, where the members aren't going to feel like they're being told where to go. We're not going to tell anybody where to go. We're just going to help them navigate the complex system of healthcare as we know it. So that, and then the other thing that is important is with this solicitation is just the financial arrangement. And so I don't say just the financial arrangement, but the financial arrangement. So if we were going to transition from a self-insured product to potentially a fully insured product, that would mean that potentially some of that surcharge that we have in the PPOs right now to replenish those reserves, so our savings in the healthcare fund, that would be reduced or go away. And so those are the things that will be happening over the next year as we release the solicitation in a couple months, and then go through that solicitation process, the competitive negotiations, all of that. So those are the things that I see that will be coming
to keep an eye out that will impact the PPO space in particular.
Due to the disparity between the markets in SoCal and NorCal, has there been consideration in splitting those risk / rate pools?
So, so for public agencies and schools, they are not, I'll say they're split now, but we do make the adjustments for them. And so keeping them together in the risk pool situation is best for everyone because we have the largest amount of members in that pool. But we do make the adjustments based on the regional pricing, where we know Northern California is about 30% higher than Southern California. That's where we do that based on our region. So the two separate things, the risk pooling of it and versus the regional pricing.
We've heard that some providers do not want to see Anthem patients given low reimbursement rates. Can you provide context for this, seeing that PPO premiums are high?
So Anthem is a strong negotiator. And so they are typical, and they have the largest networks typically. And so they typically are able to drive the lowest amounts with the providers that they contract with. So from a provider perspective, I can see that maybe that is the case, that they're not able to charge as much for Anthem patients as they are for another entity's patients. But that is what Anthem offers, and that is what Anthem does and how they do this through their negotiations. They're very strong when it comes to negotiating really good contracts. And sometimes it is not appreciated from the member or employer perspective, but the better they can get the rate with the entity they contract with, the less we have to pay for in our premiums. So,
with an increased out-of-network deductible, will the member have to meet 2 deductibles separately if some of the providers they are seeing are out-of-network and some are in-network?
It'll be split. So there'll be 2 deductible limits. So the in-network will have its own deductible limit and the out-of-network will have its as well.
Okay. Can you recap what is meant by 2 risk pools, just to be clear on understanding of this new approach?
So the approach is to go from 2 risk pools currently for HMOs and PPOs to 1 risk pool. And so that is where this is what our intention was ever since 2020 when the board approved our risk mitigation strategy. And it is something that is used throughout the industry. All exchanges use it. Centers for Medicare, CMS uses it as well for all of their plans. Other states use it. And so it's really a way to ensure that we are pricing our plans based on the network and the benefits they offer versus on the population, the health status of the population. And so by merging these into one, going into 1 risk pool, we will have much more stable and sustainable PPO products for everyone who may want to decide to use them at some point, because we do see members moving between HMOs and PPOs. So having them in 2 risk pools doesn't account for that. But this is what the board has approved, and it is an industry best practice to ensure that we can have the most stable risk adjustment that we can for all of our 1.5 million members.
Okay. Why is it that Northern California sees higher rate increases when most of its rural county wages are lower than average?
And so it's because of the consolidation that exists up here in Northern California. So it's because there are very few, there's very few little competition. There's like the big players that have the majority of the facilities and positions. Wherein when you compare to Southern California, there's much more competition. They don't have a lot of consolidation that we see up here in Northern California. So that is, I know it doesn't always jive with the rural North being less expensive and wages being lower, but that is that's the situation that we see with the healthcare industry in Northern California compared to Southern California, unfortunately.
Can you go over again the rates for each region? Are the basis data, baseline, cost trends, risk adjustment used are from within the region?
Correct. That's correct. Yes.
Let's see. Sorry, some of these are repeat questions. Will CalPERS make available for the broader communities a product such as SIMSA, or allow public agencies to contract with CalPERS and another product such as SIMSA?
I'm not familiar with SIMNSA, but I think our marketing team can reach out to you and talk about that one, about how you can have another product for a set of your employees compared to what you have with CalPERS. So there are some options there that the marketing team can talk through.
What are your estimated % of increase for 25-26 with this 3-year phase in? I think you answered that one already.
I do not have that.
Okay. Some of these are just statements. We've had a lot of employees join PERS Gold because it was a lower price plan. Definitely not a good price now. We need a good plan that is affordable for our employees. Please help, or we will have to look outside of CalPERS Healthcare.
And we completely understand that.
Is there a way to receive a soft copy of the rates so agencies can input rates more efficiently?
I'm not sure about how we can send that or post that. We can take a look at that if it's something that can be sent out. I know we don't, there's guidelines about what we can post on our website. And so we'd have to check into that one.
Okay. Cost may necessitate a rethink of your recommendation. Our employees want as many options as possible. Please discuss with your group. When will the 2024 health benefit summary be available? Those should be posted to the website at the same time we release the health plan statement. So on September 11th, I believe those will all be posted on our website. So where can we sign up for the webinar in September? Within the next 2 weeks, we're going to be sending out emails and an employer bulletin with registration instructions. It will also be posted on our OE for employer webpage on our CalPERS website with registration links. Have you looked at Kaiser's high deductible plan options, easier transition for users than heading straight to an HSA? Many of these high deductible plans allow for some services to be covered without needing to meet deductibles.
We typically don't, and we haven't been open to having high deductible health plans in our portfolio. The research has been clear that with high deductible health plans, members actually avoid care. And so that is something that doesn't really square with our approach to care. We want to make sure our members have affordable care and can and are able to see seek services when they need it. And so research has shown that the high deductible health plans actually prevent members from getting care, and they're sicker by avoiding care. So that isn't something that we just don't agree with that approach to healthcare.
Will there be more plan offerings for San Benito County in the future? Employees are reporting that their providers are no longer taking Anthem.
So we are working on that. As I said, with our HMO solicitation, the expectation was made very clearly to all the plans to continue to expand into areas where there is not a low-cost HMO option. And so San Benito County is on the list of one of those counties that we are working with the plans to explore something. So yes, we are acutely aware of that.
Okay. And with that, thank you, everyone. We are at time. And as a reminder, the recording of this webinar will be available on our website in the coming weeks and will be emailed out to all our registered attendees. We do appreciate your time today. Please enjoy the rest of your day. Bye, everyone.